Morning. Today is a pleasure for me to present the medical student, Marina Venturini. She is in the last year. Our division of trauma surgery has participated in the Telegram rounds in the last 12 years. Usually, the resident presents the case. Today is the first time that a medical student will present a case. It's a very interesting case, and she was on call with our team when this patient arrived, and she asked me to present. Okay, you can present the case, you have the interest. So it's a great opportunity for us because it will stimulate the other students in the future in the residence too. Thank you, Dr. Marina, to prepare the case.
Good morning. My name is Marina. I'm a sixth-year medical student here at Unicamp. And first of all, I would like to thank you all for the opportunity, especially my professor, Dr. Fraga. And we'll begin today presenting a case on cervical and thoracic gunshot wounds. This case happened here near Campinas, in a city called Olambra, and it was even reported in local newspapers and media vehicles, as you can see. We have a 22-year-old male who suffered a robbery attempt around 10 p.m. while he was on his motorcycle. He reacted and he tried to escape as the robber shot him in a short distance. I tried to illustrate the case, and it was something like this. So he drove away, he kept driving until he saw an open restaurant where he stopped and he called for help. The pre-hospital unit arrived around 40 minutes later, and the patient was conscious. He was walking, he was talking. This is a video that some local people recorded when the pre-hospital unit arrived. He was walking, he was talking. He showed no signs of hemorrhage. He had peripheral pulses present, and he was breathing normally. His heart rate was around 110 BPM. He was addressed to the closest hospital. It's called Mario Covas Hospital, and the ambulance took about 20 minutes to get there. But it's the city of Hortolândia's hospital. It's not our hospital. It's a secondary hospital. He arrived about 11:30 p.m. on the hospital, and all the trauma protocols were followed. So on his primary survey, he showed no signs of airway obstruction or cervical spine trauma. He had vesicular breath sounds present bilaterally. He had the expansibility preserved, and his oxygen saturation was of 98%. His BP was 120/60. His heart rate was 112, and he had normal skin perfusion. His Glasgow Coma scale was 15 with myotic pupils. He had only 2 injuries. The first one was on his shoulder, was described as a burn injury secondary to the gunshot. And the second one was probably the entrance wound, was on his cervical region. And he showed no signs of neurological damage on the locals of the wounds. This is the picture when he first arrived at the hospital. So now we can discuss a little bit about what would you do next.
Perfect.
This is a hospital, a small hospital, where they have 120 beds. They have emergency physician on call, and they have one general surgeon on call at the hospital. They don't have CT in this hospital, and they don't have the other research like endoscopy, bronchoscopy, angiography. They don't have. If they need to transfer the patient. Just to think at this moment in a small hospital, what to do with this patient.
Thank you, doctors. Dr. Antrak, your comments, please.
Yes, so looks like he's stable, and in this setting, he needs at least one good IV. We'd probably put 2 in since it's a gunshot wound, and I would get an upright chest X-ray to see if there's if he has any foreign bodies, any bullets, or maybe he's got those two wounds. One is the entrance wound, one is an exit wound, perhaps, and it might have gone mostly subcutaneously. And then I would start there, and assuming the physical exam, based on the way the pictures look, he doesn't have any swelling hematoma. There's no crepitance. There's no air leaking out of the wounds, or in other words, no hard signs of a vascular injury. Then I would start with a plain film, and then speak with the. I guess he arrived, but you're in contact. You're in contact with the receiving hospital. If they have called you, then I would recommend that and get the reading or ask to see the image either by email or however they can show it to you.
Thank you, Dr. Antrak. Dr. Ochman?
Yeah, can you put the pictures again?
Sure, it's right here.
Yeah. So, yeah, it's been more than an hour since this happened. So, and you have no CT. So probably the best option for this patient is to be transferred to the trauma center. I wouldn't do anything in that area. You can get a chest X-ray and see if there is any bullet visible. This might be 2 entrance wound and with no exit, but there is no way to treat that patient locally. I would just transfer the patient to a trauma center. I wouldn't give him fluids. I wouldn't do anything. Just put in an ambulance and transfer the patient to a trauma center. Thank you.
Thank you, Dr. Ochman. Dr. Supa, your comments, please.
Because the patient is quite stable and we don't have the CT scan at the first hospital, I agree with Dr. Untrach to get an X-ray of his neck and his chest to check for the remaining bullet in the patient and to check for thoracic involvement of the bullet. And he may need chest tube depending on the chest X-ray finding. And you have options to closely observe the patient if he remains stable in your hospital with surgical capability. Just in case the patient develops hematoma or bleeding at the neck wound, you can go ahead and explore his neck by the surgeon. Or you can do what Dr. Hodgman suggested to transfer the patient to the trauma center. If the patient was in my hospital, I think next step, I would get the CT scan of the neck and maybe chest. But in the first hospital, you don't have CT scan, so you can get the plain film and closely observe him or transfer him to the bigger hospital. Thank you.
Thank you, Dr. Supa. Dr. Venturini, we go back to you.
So what was decided is that they would get a cervical X-ray and a chest X-ray first. So here is the image of the first X-ray, cervical X-ray, where we can't locate the bullet and we can't see any signs of fracture or damage to the cervical structure. However, once we look at the chest X-ray, we can easily locate the bullet, but it's on his left side below the diaphragm. So now with these 2 images, what would you do next?
Dr. Supa, your comments, please.
I'm not quite sure which wound was the entrance. It's difficult to tell, but from the picture that you show us, maybe the one at the right trapezius, maybe the entrance wound. And we are not sure how many bullets were shot this guy.
It was just one.
And
just one shot. Yes.
Anyway, he has a bullet in the lower body from the plain film. I think he needs to be CAT scanned to check the bullet trajectory and to check for cervical, thoracic, and abdominal organ injuries. Because he is still stable, I think to get the CAT scan for this patient would be the best option. Thank you.
Thank you, Dr. Supa. Dr. Antrak, your comments.
Yeah. So it depends on. We saw the drawing of how Dr. Venturini believes the bullet was shot from behind, with the patient's torso parallel to the road. So I mean, it actually looks like it might have been from the other direction. He was shot from the front, and then it could be that the bullet is simply subcutaneous in the left flank. But you know, I would get while there, you know, it's kind of academic. If he's really stable and it looks like there's no pneumothorax, there's no hemothorax, and it's been more than an hour, he's probably stable enough to just transfer onto the tertiary hospital. But you know, if it was easy, I would get some lateral films to see exactly what level the bullet is, whether it's subcutaneous, if it really is intra-abdominal. But I think a patient like this, we would call not immediate, but if anything, yellow. In other words, doesn't have something that needs to be fixed within an hour, or he'll succumb because it's more than an hour and he's remained stable. So I think you could do the film, and it might be something that the surgeon can take care of there. A general surgeon might be a trivial case, or it might be something more involved. But I think if a case like this, if the bullet did cross the thoracic cavity or cross subcutaneously, then into the abdomen from posterior to anterior, it's probably something that local general surgeon could take care of, depending on how well you know the surgeon and the facility. But I assume you're in communication and you've seen those films from Campinas. But if any doubt, I would just have him transfer, because it seems like he's stable enough. He doesn't need a chest tube, and there's no evidence of a blood collection and no hemothorax or hemopericardium, and he could easily transfer if you don't feel comfortable with a local surgeon taking care of the problem right there.
Thank you, Dr. Antrak. Dr. Ochman, your comments?
So a few comments. First, you have two holes and one bullet. The number of holes and the number of bullets should always be an even number. So either you are missing a bullet or you are missing a hole. So that will be my worry. I remember one case that the patient was shot in the mouth and in the chest. I took him to the OR, did the chest, and after that I was looking for the remaining bullet, and we realized eventually that the bullet went through the mouth on both sides, that broke the teeth, and the patient spitted the bullet on the field. So those things can happen. Having said this, the thing I'm worried here is, are you missing another hole? We have a protocol here that we do the primary in penetrating wounds, we do the primary, and before doing the secondary, we do what we call an extended primary survey. So we go looking for holes because it's easier to miss another hole, particularly in areas where they are not expected, like for example, in the perineum or in the axilla. So I would make sure that this patient doesn't have another hole, because those two holes appear to be a clear trajectory from one hole to the other, and maybe the patient have another hole somewhere. Or maybe one of the holes he went into the mouth and he spit it out like my other patient. It could be that the x-ray didn't show. If the bullet came from the neck and is now in the right side of the neck and it's now on the left side of the abdomen, or maybe it's still the chest, maybe in the pleural space posterior to the diaphragm, that is, unless like, it could be like Dr. Untrak mentioned, it went into the subcutaneous tissue, but if it went into a cavity, it's a transmediastinal gunshot wound, and that's very serious. So my argument for not doing any more testing here is that this patient should be seen. Essentially, you're wasting time when you're doing more x-rays in a facility that don't have the capability, that doesn't have the capability to fix the problem. So we see this here too. Sometimes patients have 10 CT scans before they transfer. If you don't have a surgeon who can deal with any problem that this patient might have, don't do any CTs or any x-rays. Just send the patient, send it to a place where the surgeons can deal with all the problems. Because otherwise it's a delay in time. They might do the wrong test, or the test might not be transmitted or saved to a CD for you to see it when the patient, and you need to repeat the test. So I wish this patient, this situation, hemodynamically stable, put in an ambulance, send it to a trauma center. It's serious enough to be seen in a trauma center. Thank you.
Thank you, Dr. Ochman. Dr. Venturini?
So here's another instance of the chest X-ray and the abdomen X-ray as well, where we can locate the bullet. And as my professor was explaining, Mario Covas Hospital is a secondary hospital. And although they do have surgeon and emergency physicians there, they don't have a CT available. So the next step was transfer him to a trauma center that we have here at Unicamp. So the patient was transferred to our hospital. That's about 40 minutes away from where he actually was. So he arrived here at 4:58 a.m., still walking, still talking, with no signs of neurological damage. His ABCDE was very similar to the one reported at the first hospital he went to. And he didn't have any chest pain, any dyspnea. He didn't have any major bleeding. He was fine. And once he was questioned about the trauma story by our team, he remembered that he spat some amount of blood on the floor while he was on the restaurant asking for help. So now with the full story and on a trauma center, what would you do next?
Thank you. Dr. Rahman, your comments?
Well, I think we all been saying we need to do a CT scan. We're still missing one bullet. So I will go looking for that bullet unless he also spit has a chance to spit the bullet out like my patient, but that's kind of very rare. So I will be looking for another bullet with a CT scan. Thank you.
Thank you, Dr. Antrak.
Yes, I agree. CT, neck, chest, abdomen, and pelvis with oral contrast.
Thank you. Dr. Supa, your comments?
I agree with CT scan and looking for another hole more aggressively, like Dr. Hodgman mentioned.
Thank you, Doctor.
Okay, will you present the CT scan? I invite Dr. Cleo. She's a resident in radiology, and she will present the CT scan.
Hello, good morning. So beginning with this video, we have the CT of the brain in the bone window. Here in the beginning, I'm going to stop to show already that we have some irregularity of the subcutaneous on the posterior left posterior subcutaneous of the neck, as you can see, going upwards, trying to find some hints about the pathway that the bullet took inside the patient. We see already a comminuted fracture of the pterygus process, the medial and the lateral lamina. And also we can see a fracture of the vertical lamina of the palatine bone. No other important findings in this exam. Looking here on the sagittal plane and in the coronal, just a sec. What is interesting to see here is that this part of the bone structure of the head, mainly the vertical lamina of the palatine bone, it delimits a cervical space, which is the pterygopalatine fossa. And looking on the next here, maybe this. Okay. And this space separates from the nasopharynx through this little bone. So apparently the bullet hit this bone, made this comminuted fracture and lost its energy here. And maybe apparently simply fell into the nasopharynx. As we can see, there is like an asymmetry of the soft tissues, like just once here, there you can see like the sternocleidomastoid muscle is swollen, the pharynx has a swelling of the mucosa, but no other findings beside this fracture. So we proceed trying to understand what the bullet did inside of the patient's body. With a thoracic and abdominal CT, trying to understand where is the bullet. So no pneumothorax, no hemothorax, we can see the bullet projected in the gastric camera and no other findings in abdomen also. We don't see like free fluid. We don't see any sign of bleedings. Just, yes, the chest, I didn't even put like the parenchyma window because there is nothing, no findings. So we are trying to understand now, is it loose in the gastric intestinal tract? Is it like stuck in the gastric wall? So just some pictures here. So this is what we had on CT, and we are trying to understand like if it didn't really made any perforation, there was no free fluid, as I said, no free gas. So some hours after this exam, we made like a control, and the bullet was really going downwards through the gastrointestinal tract. So I guess the image was mostly that.
Now with these images and after Dr. Cleo's speech, what would you do next?
Thank you, Dr. Antrak. Your comments?
Yes, so it's a new one. So maybe it's like a buttonhole, the bullet, you know, through the in and out of the burn on the shoulder, and then entry into the neck, and then the drawing like Dr. Venturini showed initially, it lost its energy, and the when it fractured with the ethmoid plate and then he swallowed it. And just check his stools, wait for him to pass the bullet, just ask the nurse, whatever. But and then it looks like there's no violation of the aerodigestive tract. So the issue is what to do for do you need to do anything for the fracture? And you know, I'd ask the ENT people, but you know, it's kind of a very considerate assailant that he just shot him so innocently. But and he survived the 6 hours to get to your hospital with no change in his vital signs. So it really suggests that he didn't cross the mediastinum. He had no major vascular injury, but it looks like that's what happened here. So, and that there's only one bullet that you found. And so I would, just to be sure that there's no aerodigestive injury, it looks like there isn't, and then see what the ENT people say. But what a freak case, freak accident here.
Thank you, Dr. Antrak. Dr. Supa, your comments?
I agree with Dr. to call ENT people to check his nasopharynx. And I think I would perform EGD to be sure that he doesn't have any esophageal or gastric injury. And I'm not going to try to remove the bullet at this point because it has gone too far. He will pass it with his stool eventually. And after that, I would closely observe the patient for epistaxis or CSF leakage. Thank you very much.
Thank you, Dr. Supa. Dr. Ochman, your comments?
Yeah, I agree with Dr. Supa. I will do an endoscopy. I am still worried that you have 2 holes and 1 bullet. So did he spat 1 bullet and swallow the other one? I don't know, but I will be concerned about a pharyngeal or upper esophageal injury, and that's the bullet that he swallowed. So I will do an endoscopy too. And you need to treat the other one as an open fracture. So when talk to ENT, probably put him on antibiotics for a few days because he didn't receive antibiotics immediately. But that's all so far. That I don't have anything else. Thanks.
Thank you, Dr. Ochman. Dr. Fraga, Dr. Venturini.
So next step for us was to do an endoscopy, and we performed the endoscopy to search for lesions or possible perforations, and we didn't find any. Actually, we found a hematoma on the right side of his larynx, and on his stomach we found the bullet, which was successfully removed with the endoscopy. And 12 hours later, we performed a video laryngoscopy to assess possible airways or larynx damage or perforation, as well as the need of nasoenteral feeding tube. On these images, we can clearly see the hematoma on the right side, but we didn't found any lesions or any perforations. So patient was discharged with antibiotics. His wife is a nurse technician, so she was constantly in contact with our trauma team. And he returned 5 days later at our outpatient clinics here in Unicamp. And this was a picture of him Friday when he returned and in a consult with us. He was breathing normally, he was eating normally, had no bleeding episodes since he left the hospital. So there isn't anything left to do. That's the case we wanted to present and discuss with you today. And thank you very much.
Thank you, Dr. Venturini. Dr. Fraga?
Thank you, Marina. We discussed a lot about put a TGI tube to feed this patient, but there was not an obvious perforation. So we started to give liquids for him, keep with antibiotics, and we follow the patient with his wife very close. Every day send us information about signs of infection, and he recovered well. Today you have 8 days that the trauma occurred. We are still following this patient, but it's a picturesque case, very, very different case. The most important thing you learn with this case is about the mechanism of trauma, because this guy, he was in his motorcycle when he just tried to line the motorcycle, and the first hole was in the shoulder. The exit was in the cervical area, but not exit because the projectile go ahead and go to the nasopharyngeal area, and it just fit the projectile. So very interesting, different case. I hope you have appreciate this case. Let's go to final comments.
Sure. Dr. Fraga, there is a question in the chat. Any injury in the oral cavity? I'm not sure you answered that already.
No, in the oral pharynx was only hematoma. Only a hematoma, but the mucosa was intact, no perforation.
Okay. There is another question.
No injury in the oral cavity. No injury in the oral cavity. No injury.
Okay, perfect. Okay, so yes, we can go to final comments. Dr. Supa, your final comments?
Thank you very much for the presentation. I enjoyed this case a lot and learned a lot as usual. Amazing case and very good management. Thank you.
Thank you, Dr. Supa. Dr. Antrak?
Yeah, very unusual case. I wouldn't expect to see one of these, and I wonder what kind of pistol would that have been, that the bullet had so little energy, but that, I guess that worked out well for the patient. So I guess the perforation was through the nasopharynx, but in that, did the ENT people see the patient? I mean, I assume that they would have probably done the same thing, that you know, if the perforation were in the hypopharynx or cervical esophagus, it would have required a repair and or drainage or diversion. But you know, the question is, for this kind of a perforation of the nasopharynx, does it? I suppose it doesn't require it because it's out of the line of the digestive tract. But very interesting case. Did the I assume that you asked the ENT surgeons and they recommended the same treatment. So I gather that this kind of an injury, you don't need to do any kind of diversion or drainage.
Yes, they saw the patient and they were following along with us. We were constantly in contact. They performed the video laryngoscopy.
Thank you, Dr. Antrak. Dr. Ochman?
Yeah, very unusual case. I have to say this surprised me. If you don't mind, Dr. Fraga, to put the pictures, the initial pictures of the injuries, I had the feeling like Marina mentioned, the track was that direction, and the jag edges on the on the upper portion, that the upper wound has jag edges, probably because it kind of skimmed under the skin there before going back in. So it looked like the trajectory was, as Marina put in her initial picture, very, very unusual to have this that goes through part of the skin, but the bullet remains inside and keep traveling. The injury would be in the back of the nose where the fractures were, so that's the reason probably nothing is seen in the mouth. But this is very, very, very unusual, very interesting, very confusing, and always show that never assume, always look for something else, some other explanation. One of the questions in the chat asked the possibility of the bullet embolizing distally. It's difficult for the bullet this side. By the pictures appears to be a 9 millimeters. It's difficult to embolize distally without having a major vascular injury, but it's possible. I have an interesting case, one that I couldn't publish because I didn't get permission from the patient or his mother. He was 16-year-old who shot himself with a BB gun in the chest, in the right parasternal space. He got here like 12 hours later, has a very, very small pericardial effusion that we just watched it because it was 12 hours after that, and the patient did well. Very unusual for me to watch a pericardial effusion, and the BB embolized to the pelvis. How he went from the right side of the heart to the left and embolized to the pelvis, I really do not know. I did an echo at that time, trying to find a atrial septum defect or a ventricular septal defect. Didn't have any. So somehow the BB ended up in one of the small vessels in the pelvis. So those things can happen. They're very rare, but this is also a rare case. So it could happen. Yes, absolutely. This is good. This is the advantage of this type of conference. Always new things, that always the unexpected, and keep us in our toes. Thank you, Dr. Fraga and Marina. Great case.
Thank you. Thank you, everyone.
Thank you. Just two aspects of this case. On admission at the hospital, I was on call. I asked him, I look in the mouth to look for another injury in his mouth. No injury. And I asked him if he had bleeding, something, a cold, if bleeding, hemoptysis. No, he told me, no. After the X-ray at our hospital, we were suspect that the bullet was in the stomach. I come back and asked him again, you are sure? Nothing like blood? I was in my motorcycle, I started to blood on the neck, I put my hand on the neck. After stopping a restaurant, because there are some people there, he stopped the motorcycle to ask for help. I had a little of blood in my mouth, but very, very little amount. Okay, but there was some blood in the mouth. And when he was in our hospital, I look in the trajectory of the projectile if he had pain. No pain in the trajectory of the projectile. But when he came back last Friday, 5 days after the injury, he had pain in the trajectory. Very, very interesting. I just went there to examine him, and there was pain. So it's for learning, because when you have gunshot wounds, I put in the title, thoracic and cervical gunshot wounds. When you look in the picture, you need to think easy. Oh, probably you have 2 gunshot wounds, 2 bullets. But we identified only 1 bullet and was in the abdomen. So it was a very nice case, and Marina is prepared to relate this case and publish this case because it's very unusual. So thank you for your comments. You learned a lot with this discussion. Thank you, everybody.
Thank you. Dr. Antrak, do you have a question?
Yeah. So to go back to that last slide, I guess then you're a proponent of for the second time now. The first time was about 49 years ago, and now you're raising it the second time of the single bullet theory, I think is what we're talking about here. Is that right? So the one bullet where you said the burn wound over the shoulder was just not an entry wound, but just that the bullet skiving along the skin tangentially, burning a hole in the skin without actually entering, and then a single entry wound in the neck that caused the injury. That's your theory? Is that right, Dr. Venturini?
Yes, yes.
Yes. And when I say the second
Probably
time in single bullet theory, the first time was after the tragic assassination of President Kennedy. But anyway, so a single bullet, and that's why you described it that way. It's a very interesting case and raises a lot of red herrings in this case.
Thank you.
Thank you. Thank you, everyone. Let me share my screen with the code. Thank you, Marina. Thank you, Cleo. Thank you, Dr.
Valeria,
Fraga.
Can
Yes.
I make invitation for everybody?
Sure, of course, Dr. Fraga.
There is a campaign in Brazil about prevent road traffic injuries, to prevent trauma. It's called Yellow May. Yellow May. It's a movement to call attention of the society with the rules to drive the car, no alcohol and driving, and no use of cell phone while driving. So it's a national movement, but in the last years became an international movement, like a campaign. So I'm sending information to different surgeons in different places. If they want to join this movement, this campaign is very interesting, just to talk about prevention, to prevent trauma. So I will send email for everybody in the next days. It starts on May 2nd. It's a Monday on May 2nd, and Dr. Martos is organizing a special session for the first Monday on May to present this program with surgeons from different countries. I think it's very important we work with prevention. So everybody is invited to join this campaign.
Thank you. Thank you, Dr. Fraga. Yes, we will send shortly the information as soon as Dr. Martos and Dr. Fraga provide it. Thank you very much, everyone. I hope to see you next week.